Our lecture today is on sleep disorders, and this was a challenging topic to try to decide exactly how much to cover. As an example, the latest version of the International Classification of Sleep Disorders has a total of 85 sleep disorders that fit into 8 major categories. But I think in this lecture I've covered the most common types of sleep disorders. So as a basic principle, we all know that sleep is important, but I would say a lot more is known in recent years just in terms of how important sleep is. In terms of just memory function, executive function, the ability to maintain good attention throughout the day. Getting a good night's sleep is extremely important for all of those things, and we really have a lot of good evidence to support that. Another important function of sleep is a lot of clearance of toxic substances in the brain occurs during sleep. I'll just mention beta amyloid as one. So obviously you want to have good clearance of that, and that does occur during sleep. So let's talk a little bit about areas of the brain that are important for wakefulness and also what happens in those areas during sleep. And so I certainly wouldn't try to remember the difference between 2 up arrows and 3 up arrows, but we can see, of course, norepinephrine is activating. Serotonin is also very active during wakefulness, as is dopamine, histamine, acetylcholine, whether it's produced in the basal forebrain area, the nucleus of Maynard, or down in the pons, not as active here during wakefulness. Glutamate, of course, is an excitatory neurotransmitter, and orexin we'll say quite a bit about in this lecture. Orexin is produced in the hypothalamus, and this is mainly released during movement. Now, sleep we will divide into a non-REM and a REM stage, or rapid eye movement. And so again, some of the subtle differences here, not critically important, but I'll just mention a couple of things, especially here. It's important you know that the acetylcholine that is produced in the pons and projects up to the brain, this is not active at all during non-REM sleep, but this is the main part of the nervous system that we know of that's very active during rapid eye movement sleep. Okay, so you want to associate acetylcholine coming from the pons as being very active during REM sleep, and you can see dopamine as another neurotransmitter that is involved during REM sleep. Okay, so again, acetylcholine, most important here from the pons with regards to REM sleep. All right, so these are areas of the brain, we call them the ascending arousal system. And so there's this back and forth kind of an interplay between areas in the hypothalamus and these arousal centers in the brain. Okay, so we can see mainly these are in the pons, upper pons, and midbrain area, so like the locus ceruleus and other areas that produce the neurotransmitters that we can see here, raphe nuclei, and so on. And so what happens then during sleep is in the hypothalamus, there are a couple of areas that are very important. One is the ventrolateral preoptic area, which we can see right here. Okay, and this area, when we fall asleep, the ventrolateral preoptic area is activated, and it shuts down all of these ascending arousal areas of the brain, and we fall asleep. And when we wake up, these arousal centers in the pons and the midbrain become relatively more active, and they then inhibit the ventrolateral preoptic area. So there's this kind of back and forth communication here, kind of an on-off situation that occurs either when falling asleep or when waking up. All right, so what happens during drowsiness? The feeling of just being drowsy, I feel like I need to sleep. That seems to occur, so here's the ventrolateral preoptic nucleus, but there's a medial portion here called the medial preoptic nucleus. And when you get drowsy, this is probably adenosine that is active here in activating the medial preoptic nucleus. Okay, and when that happens, then it activates the adjacent area, the ventrolateral preoptic nucleus. Okay, and so again, that's what then causes you to fall asleep. So you want to think of the ventrolateral preoptic nucleus as really important for maintaining sleep throughout the night. But the actual initiation here, when you become drowsy and fall asleep, what's happening here is it's the medial preoptic nucleus that then activates the ventrolateral preoptic nucleus and you fall asleep. Okay, so medial preoptic nucleus is for sleep induction, and then the ventrolateral keeps you asleep throughout the night. Okay, and again, when we wake up, then the ascending arousal system becomes relatively more active and it inhibits the ventrolateral preoptic nucleus. And this really does happen very quickly, and it's been described as an on-off switch or a sleep-wake switch. And it's a good thing that it works this way, just because otherwise we would have these very long, imagine taking an hour or two to fall asleep and to wake up every morning. But it really does happen very quickly. 1 minute you're awake, the next minute you're asleep. It's on-off. Now, another important area, sort of adjacent here in the hypothalamus, are these orexin neurons, sometimes called hypocretin neurons. These are in the posterior lateral hypothalamus. Okay, and these are activated by any movement. Okay, and so they can then stimulate the arousal centers. If you've ever had the experience, you're driving a car and you're feeling kind of drowsy, well, if you just tap your hand on the steering wheel or tap your foot, you'll notice you feel more awake. And so what's happening there is the orexin neurons here, which are stimulated by movement, then enhance the activity here in the arousal centers. And that's why it's nearly impossible to fall asleep when standing up, because again, those orexin neurons are quite active. Now, another important area of the hypothalamus is the suprachiasmatic nucleus, which we can see right here in red. And we can see that this has a direct pathway from the retina to the hypothalamus, okay, specifically to the suprachiasmatic nucleus. This goes to the paraventricular hypothalamic nucleus, among other areas, but that's most important. And from the paraventricular nucleus, this then activates actually the sympathetic system. So kind of think of light activating the hypothalamus, the sympathetic system here to, again, help to maintain wakefulness. But we'll notice that also this sympathetic system, remember that for dilation of the pupil, it goes from the hypothalamus down to C8T1 and then all the way back up to the pupil. Well, there's kind of a parallel pathway here that goes up through the superior cervical ganglion, but now not to the pupil, but instead to the pineal gland. Okay, so light stimulation via the sympathetic system here actually serves to inhibit the release of melatonin from the pineal gland. So again, light stimulation will decrease the release of melatonin. All right, so this is really the suprachiasmatic nucleus is called the biological pacemaker here. And so it sets the circadian rhythms. And so light is the source for all of this. Okay, and so just examples of this, sleep-wake cycles, of course, are very much timed with light stimulation here. Feeding, and the desire to eat at certain times are part of the circadian rhythms. Temperature, of course, body temperature goes down quite a bit at nighttime. That's all established by circadian rhythms. And again, a lot of that does have to do with melatonin, which is released at dark. Now I'm going to introduce polysomnography, which is a test that we do for some patients that have sleep disorders, because we'll illustrate a number of things from this as we go through specific conditions. So when we bring someone in for a sleep study, we do three things, sort of as objective things we can measure during a sleep study. First, we do an EEG, and I didn't go over the normal rhythms during the seizure lecture, so I'll introduce them now. Beta frequency is really not that important. This is often seen as a rhythm maybe due to a medication side effect. But alpha frequency, this is something we evaluate mainly in the back of the brain, occipital lobe, and this is 8 to 13 hertz and indicates that the patient is awake. Okay, as a patient becomes drowsy and then goes into deep sleep, we see them merge into a theta, which is 4 to 7 hertz, and then delta, which would be deep sleep, is 4 hertz or less. Now, along with that, we do an electrooculogram, and so we put electrodes on either side of the eye. And it turns out the cornea is just a little bit positive, the retina is a little bit negative, and so when the eyes move during sleep, which is really important, we can evaluate that, like for rapid eye movement sleep, we can pick up those eye movements here by just putting these electrodes on either side. And then we actually do some EMG testing during a sleep study. This is not done with a needle into the muscle, like when I talked about EMG of the arms and legs, but you can put a surface electrode over the submentalis muscle. That's usually the one that's evaluated, and then you can evaluate for muscle activity there. All right, so normal sleep. Okay, we have stage 1, where the patient goes from alpha wake rhythm into a theta rhythm. This is kind of an early drowsy light sleep pattern. As the patient moves into deeper stages of sleep, stage 2, we see these K complexes and sleep spindles, and I highlighted sleep spindles because that just seems to be kind of a high yield, that if you can associate sleep spindles with stage 2 sleep, and half of the night for most people is spent in stage 2. So when we bring someone in for a sleep study, or even just someone comes in for an EEG and they fall asleep, if we see sleep spindles, we know that they're in stage 2 sleep. Stage 3 and 4, you can see it's delta sleep, and so by stage 4, more than half of what we see are these kind of high amplitude, very slow waves in the delta range. All right, so we divide sleep overall into two big categories, non-REM sleep and REM sleep. And so as the name indicates, of course, we're going to see a lot of eye movements during REM sleep, and absent eye movements then are seen during non-REM sleep. With the exception that when someone falls asleep in stage 1, their eyes roll back and forth a little bit. We call those slow rolling eye movements. And so we see that during stage 1, but otherwise the eyes don't move during non-REM sleep. Okay? Now, what about the submentalis muscle activity? Well, when you fall asleep, movement is overall reduced, right? That's not surprising, but it's not absent, so there'll be a little bit of movement. Whereas in REM sleep, the EMG activity here is completely absent. And so there is normally muscle paralysis during sleep, during REM sleep, with the exception of eyes and, of course, breathing, but otherwise there's paralysis, which is good because otherwise you're going to be acting out your dreams at nighttime. Okay, so an alpha rhythm is during wakefulness. And we have a theta rhythm, which is either 4 to 8 or 4 to 7 hertz, and then 4 or less would be a delta rhythm. Okay, and you don't need to recognize this, but sleep spindles and K complexes, if we see those on an EEG, again, we know the patient's in stage 2 sleep. Okay, so I don't expect you to make anything out of the EEG here, so I mainly want to emphasize these latter two categories. So during wakefulness, there's a lot of EMG activity, right? We move a lot just when we're awake. And of course, we're going to see lots of eye movements. When someone is in REM sleep, there's muscle paralysis. So you see really no EMG activity. But lots of eye movements, right? Because it's rapid eye movement sleep. compared to non-REM sleep where the eyes don't move. Okay, and we see a little bit of EMG activity in contrast to REM sleep where there's no EMG activity. Now, sleep stages during the night, this can range quite a bit. It's usually 4 to 6 stages in total. But we can see here when someone falls asleep, they go pretty quickly down to stage 1, 2, 3, 4. And notice the longest period of deep sleep tends to occur during the first hour or so. Okay, and then patients move up into maybe around 1 hour or a little later, the first period of REM sleep. And then there's another period that goes down into the deep stages of sleep, and then a longer period of REM sleep. And then the next phase, maybe the patient doesn't get down into stage 3, 4 sleep. Notice a really long period of stage 2 sleep. So remember, half the night is spent during stage 2 sleep. And then another REM period. Now it doesn't even go down into stage 3 in this cycle. And notice as you move, later, towards the end of 8 hours, sorry to insult you by suggesting you get 8 hours of sleep every night, but notice here during the last 2 hours, there are these little periods of waking up briefly. Okay, and actually we wake up a lot during the night, but they're so brief we don't remember them in the morning. Okay, and notice here a couple of really long periods of REM sleep right before waking up. Okay, so the general rule is the deeper sleep occurs during the first third of the night. REM sleep becomes more prominent towards the end of a night's sleep, and that overall stage 2 sleep makes up the most common phase of sleep during the night. Okay, so this is pretty much what I just went over here. REM sleep for most individuals makes up somewhere between 20 to 25%, although in infants, half of the night is REM sleep. And so just with the aging, the changes during teenage years are often quite pronounced. I'll talk a little bit about this later when it merges into a disorder, but teenagers are known for staying up late and sleeping in, and this actually is a normal physiology that happens during teenage years. There's just a natural, it just seems right, and it's part of the biological clock during those years to stay up late and to sleep in. Okay, whereas in the elderly, we often see the quality of sleep diminish a lot with normal aging. Stage 3, 4, and 3 and 4 sleep can disappear entirely in the elderly. So that means they wake up more easily because they don't go into the deeper stages. That along with issues with prostate and needing to go to the bathroom a lot at nighttime and maybe pain and other things overall tends to lead frequently to poor quality of sleep in the elderly. You can see that newborns, 50% of sleep is REM sleep. If you've ever watched a newborn, they often have just these incredible eye movements. It's just worthwhile watching a baby sleep sometime. But we can see that diminishes with age, and in the elderly, REM sleep may significantly diminish further. So remember that REM sleep, the acetylcholine production from the pons is very active, and we know that just tends to diminish in the elderly. Okay, so just again, sleep efficiency declines with age, and that saying to sleep like a baby just becomes more uncommon as one gets older. So here are the general sleep requirements, and we can see that an infant may sleep up to 18 hours per day, and so this is going to diminish. And so notice teenagers should be sleeping between 8.5 and 9.25 hours, and this is going to vary somewhat, but this is actually pretty good evidence-based information here. Because teenagers stay up late and have frequently, an 8 o'clock class or whatever in the morning. They're often sleep deprived during the week, and then will sleep much more on the weekend. We'll sleep past noon on Saturday or Sunday to try to catch up. So we can see older adults often sleep just between 5 to 6 hours. Okay, so the sleep requirements do go down with age. All right, now we'll go through some sleep disorders. First of all, insomnia, which can be either a difficulty falling asleep or frequent waking up at nighttime. And by definition, insomnia does need to result in some daytime impairment. So we'd only diagnose insomnia, if someone's having symptoms during the day. They're fatigued, they're sleepy, just not feeling well during the day as a result. So here are some different subtypes of insomnia. Paradoxical insomnia. This used to be called sleep misperception syndrome. Surprisingly common. These are individuals that report that they don't sleep well, and we bring them into the lab for a sleep study, and we're monitoring, the EEG. We could see, boy, the patient slept the whole night. It seemed like just a perfect sleep. And then we ask the patient about it, and they say, yeah, I didn't sleep at all. Tossed and turned, couldn't sleep at all. And we have, on record, video and everything, a normal sleep. All right, so it's a bit unusual, and maybe in the clerkship we'll talk a bit more about how you would approach someone with that. Psychophysiological insomnia is very common in individuals that have a lot of stress, commonly seen in students, maybe related to having exams. And so these individuals have a hyperarousal and really an over-concern with the ability to sleep. And so when going to bed, they're afraid they may not be able to sleep. And so when they begin to get drowsy and fall asleep, then they become suddenly very concerned. Am I going to fall asleep or not? And then that can prevent them getting to sleep and will cause insomnia. Now, when we're talking with someone about insomnia, this can sometimes be related to anxiety and depression. And the general rule is anxiety will cause difficulty falling asleep, whereas depression, the issue is more early morning awakening. So they might fall asleep, but then wake up at 3:30, 4, can't get back to sleep. That would be more consistent with depression. Interestingly, sleep tends to be not much of an issue with other conditions such as schizophrenia. Now, there are a lot of medications, illicit drugs, alcohol, things that tend to interfere with the normal quality of sleep. And so I'm not going to go through all of those, but just to say it is really important that you do an inventory of all of those things. Are you taking anything over the counter? How much alcohol? Do you use marijuana or any other drugs? You need to compile all of that evidence, because that will help you when you counsel the patient. And then poor sleep hygiene is a very, very common issue. So I'll just mention a few of the more frequent problems here. For anyone that, if someone is able to sleep well, whether they go to bed at 8 o'clock or 1 in the morning, then that's fine. But if someone is having insomnia, it becomes very important that they have a regular sleep time. And so when someone is reporting insomnia, we'll ask them to keep a diary, when did you go to bed? And so what we'll frequently find is a very chaotic sleep schedule. And so if we're really trying to establish good circadian rhythms and a good sleep pattern, it's important you try to stick to the same time roughly for going to bed and the same wake-up time. Also, activities that tend to be alerting prior to sleep. So again, think of the circadian rhythm. If you're looking at a bright iPhone, in the last 30 minutes in bed before you go to sleep, that's really not a healthy thing to do. That's going to promote difficulty falling asleep. Exercise, of course, is to be encouraged, but if you do that right before bed, that can make it difficult to fall asleep. Caffeine, if someone has insomnia, they really shouldn't be drinking caffeine after noon or so. And again, alcohol, smoking before bed, can be counterproductive. So alcohol may promote falling asleep, but frequently what happens is the alcohol wears off a little bit, then there can be a wakefulness, 3-4 hours later. And individuals that take naps during the day then will frequently have difficulty sleeping at nighttime. And so we usually will encourage in someone that has insomnia to try to eliminate the naps and see if we can make the sleep at nighttime better quality. So this is what I give patients that have insomnia. This is from the National Sleep Foundation, Healthy Sleep Habits. So at night, use the bed in the bedroom for sleep and sex only. These are their guidelines. So, for example, many medical students have a hard time, especially during the first and second year, because you're just studying hard, the stress of exams. And so if you have insomnia, and you're worried about anatomy or whatever class it is, and you don't want to associate the bedroom and sitting in bed with reading your anatomy handouts, right? Take that out of the bedroom. So just, sleep and sex only, that's the rule of thumb for what should be done in the bedroom for individuals with insomnia. Again, a very regular routine is important. Don't eat or drink too close to bedtime. Create a nice environment. Go to some work to make sure that things are dark. You want really a cool temperature, a very comfortable bed, obviously. Frequently, a white noise machine can be helpful to try to block out external sounds that might be alerting. And then during the day, remember caffeine shouldn't be taken after noon or so. Alcohol, smoking, especially close to bedtime, should be avoided. Exercise, again, encouraged, but as a rule of thumb, not closer than 3 hours before going to bed. Avoid naps, and a sleep diary can be invaluable. So I have a form that I give patients where every day they can just check what time they went to bed, did they take a nap, how much caffeine did you use, those kinds of things, and then you can see the patient back with that and give them some advice based on their sleep diary. Now, in terms of treatment of insomnia, I first should mention that if you can do this through behavioral modifications, and cognitive behavioral therapy can actually be quite helpful and really is preferred if possible. Relaxation techniques, things where we can address insomnia without just giving the patient medications. But if we do need to use medications, I'll go through what is approved by the FDA for insomnia. So first of all, we have our GABA receptor agonists. And so these categories, they're actually divided into a benzodiazepine receptor agonist and a non-benzodiazepine receptor agonist. Really, these distinctions are not helpful or useful at all. So I will not, they're categorized this way, but they really don't seem to have much of a functional difference. And so here are 3 of the common benzodiazepines that are used: flurazepam, temazepam, and zolpidem. Many of you have probably heard of Ambien for sleep. And so these are all frequently used, but really they should be used for a short period of time. Because the problem is when patients use these for month after month and year after year for sleep, it can become almost impossible then to fall asleep at all. And when patients try to go a night or two without taking them, they have a rebound insomnia. They've just got to take it every single night. So these can be helpful, but ideally it's a short-term measure. All right, so here is the GABA receptor here. You can see it has 2 alpha and 2 beta subunits and a gamma subunit. And so here we can see the GABA neurotransmitter stimulates this. And remember, it causes the influx of chloride. Okay, so here we see the areas for GABA receptors. And then we also have binding for our benzodiazepines and barbiturates. Remember phenobarbital or barbiturate anticonvulsant we talked about. And so here we can see some of the benzodiazepines binding here and the barbiturates here. So GABA, of course, is inhibitory, and that's via the influx of chloride. All right, other FDA-approved medications, there is a melatonin receptor agonist. So you're not giving melatonin. That's actually not really proven for insomnia. But a melatonin receptor agonist, this is known as Ramelteon. Okay, and also FDA approved is a histamine antagonist, doxepin. Doxepin is actually a tricyclic antidepressant, but it's unique and it has a very strong action here against the H1 histamine receptor. So in a low dose, doxepin can actually be quite helpful. And less likely to get into that rebound insomnia than we see with the benzodiazepine medications. Now, what you will see in the real world is that a lot of physicians use other medications that are sedating. There really isn't a lot of evidence-based medicine really to know, to support the use of this, but these are very commonly used. And I would say most often trazodone, which is an antidepressant that, like doxepin, has a strong action against histamine, and gabapentin. Remember, that's an anticonvulsant, frequently used for pain. It's a little bit sedating, so patients can take some gabapentin before they go to bed. So these are frequently used, but again, we don't have good literature to support how effective they are and how they should be used. I think I've mentioned before, I would just encourage sometime, maybe when the pandemic quiets down, go to a pharmacy and just walk through the aisles and look at the different medications. And what you will see is that most of the over-the-counter sleep medications have diphenhydramine. Okay, so this is an antihistamine, excuse me, which is quite helpful to promote sleep. It frequently tends to linger into the morning, though, and patients will feel thick-headed when they wake up in the morning. And anytime you've got a difficult problem, and it's common, you will find just 1,000 different home remedies and other things that can be taken over the counter. And, certainly patients may get a placebo response from this, but for most of these, there's really no reason to think that they're helpful. Now, our next category will be sleep-related movement disorders. Restless leg syndrome is extremely common. And so these patients describe having this sensation in their legs which prevents them from getting to sleep. And I've just heard this so many times that it's almost persuasive to me when I ask a patient to tell me what's the feeling like in the legs, and they usually will say it's hard to describe. Okay, so that's almost believable. And so it's a feeling like maybe something creepy crawly in the legs. It's usually worse below the knees, like in the calves. And it's a very uncomfortable sensation. And it occurs almost exclusively when patients are lying flat and trying to get to sleep. All right, so just before sleep, that uncomfortable sensation occurs. And then patients will say if they stretch their legs or if they get up and walk around a little bit, it's dramatically improved. Okay, but then they go back to bed and then the feeling comes back again. So again, very common, and it's hereditary, and it's also highly associated with iron deficiency. And it's actually known now that there are low levels of iron in the basal ganglia. And so first thing we do when we diagnose restless leg syndrome is we check a ferritin level. And if the patient is iron deficient, then we'll treat them with iron replacement. I didn't mention in the handout, but we always give patients vitamin C along with that because it promotes absorption. Now, if someone is not iron deficient, then we have two choices in terms of medications. The pramipexole and ropinirole, the dopamine agonists we talked about for the treatment of Parkinson's, work really well. They're highly effective, but increasingly we're finding that patients who have been, particularly if they've been on a high dose of either pramipexole or ropinirole and over a long period of time, frequently experience what's known as augmentation. And so the story here is, patient has restless leg syndrome, maybe they had a really good response to pramipexole, but they needed a higher dose over the years because their symptoms were getting worse. And every time you'd increase the dose, they'd get better. But then after a certain point, increasing the dose to try to keep up with the symptoms actually seemed to worsen the symptoms. And now you've got a patient having horrible restless legs, they can't sleep at all, and they're on a high dose of a dopamine agonist. And so that is known as augmentation, where the dopamine agonist actually contributes to and worsens the symptoms. And so for this reason, we still do use a lot of dopamine agonists, but we might do some things to try to avoid that, like a holiday, so to speak, off of the medication, and some other things can be done. But frequently, neurologists are now using gabapentin and acarbol. Now, this is the precursor to gabapentin, and the reason we'll usually use this is it has a longer half-life than just giving someone gabapentin. And so you can give a patient this before they go to bed at nighttime, and also works well for restless leg syndrome. Okay, there are some other things that can be done, but these would be the two most common medications currently used for restless leg syndrome. Remember that dopamine agonists in Parkinson's, I said, can cause impulse control disorder, like gambling and other issues. That can also happen when you use this for treatment of restless leg syndrome. So you also need to warn patients about that, and especially the spouse, if there's any change in behavior and so on. Now, 80% of patients that have restless leg syndrome also have what used to be called nocturnal myoclonus, but now it's called periodic limb movements of sleep. And so these are myoclonic jerks that occur in the arms and legs once the patient is asleep. And so this tends to be especially bothersome for the spouse. The restless legs bothers the patient. They can't get to sleep. But it's the periodic limb movements of sleep that are bothersome to the spouse and keep waking them up during the night. And this can be really difficult to treat. Now, probably the most common board question from this whole lecture would be on narcolepsy. And so this will be our example of a primary hypersomnia of central origin. And narcolepsy is a very interesting condition. The nutshell version of narcolepsy is that we have REM intrusion into wakefulness. Okay, and I'll explain what that means. Now, somewhere between 12 and 30% or so of individuals have this allele, but way more than 90% of individuals with narcolepsy have this. So we can't actually test this, but it becomes not very helpful when you've got something where maybe 30% of the population may have this allele. Narcolepsy, interestingly, has a bimodal distribution with a peak of symptoms at age 55 and 35. And so in narcolepsy, there is an 85 to 95% dropout of the orexin neurons in the hypothalamus. And orexin neurons, remember, otherwise known as hypocretin neurons, these are the ones that are active during movement, and they activate the ascending arousal system. So why would these neurons drop out? So let's say here is the orexin or hypocretin neurons here in the hypothalamus. And so we know that with certain things, like individuals that have streptococcal antibodies and the H1N1 influenza outbreak in 2010, both of these were associated with sort of a mini outbreak of narcolepsy cases. And so we think what happens here is that you have an antigen, say streptococcal or H1N1, that combines with the HLA protein here. And so these seem to combine and alter these receptors on T cells, which then are harmful and destroy the orexin neurons. So it's a combination of hereditary predisposition here and some antigen, infectious usually, that will lead to narcolepsy. And so narcolepsy has 4 cardinal features. So the first is excessive daytime somnolence. Now, a lot of patients will come in saying, I think I might have narcolepsy because they feel very tired during the day. Okay, and although that is a feature of narcolepsy, in narcolepsy, patients will predictably have, with just the slightest sedentary situation, a complete inability to stay awake. So there was a medical student years ago who had narcolepsy, and the poor guy just fell asleep in every class. So you get comfortable in a chair, maybe the room is a little too warm, and they just fall asleep. And so a lot of the patients that I see with narcolepsy, they're asleep in the waiting room, when you go out there. And so remember that this is a disorder of REM intrusion. And so unlike the normal sleep, when we all fall asleep, it takes a while to get to your first REM stage of sleep. But patients with narcolepsy slip right into REM sleep, and so they will often just fall asleep for a minute or two, during the day. They wake up feeling very refreshed and restored by that brief period of sleep, and can sometimes tell you about a dream they had, because they went into REM sleep very quickly. Okay, so that's one feature. The other is cataplexy. So the first two should be seen in all patients with narcolepsy. And remember that during REM sleep, there is muscle paralysis. And so this is really our classic illustration here of REM intrusion into wakefulness. And so patients with cataplexy have these episodes where they just lose all muscle tone and fall to the ground. And this is usually triggered by something emotional, oftentimes telling a joke or laughing at a joke or something like that will cause a patient just to fall over. So I have a number of patients that I see with narcolepsy, and one time a man told me a joke in the office, he started laughing, and then he fell out of his chair onto the ground. Another patient I saw for years was in a bowling league, and people joke together when you bowl, and she had several episodes where she just fell over while bowling. If you just Google dogs with narcolepsy, you will see these videos of dogs that get excited, and then they have cataplexy where they fall over. Okay, so when someone is concerned about narcolepsy because they're drowsy during the day, well, do they have cataplexy episodes? If they don't, then they almost certainly do not have narcolepsy. Sleep paralysis is something that can occur either on falling to sleep or on waking up. And so again, it's REM intrusion into wakefulness. And so, for example, waking up in the morning, and patients will be completely paralyzed. They're aware of what's going on, but they just can't move because it's the REM that is persisting into wakefulness. Kind of going along with that, hallucinations can happen either on falling asleep or waking up. So this is a dream. It's a REM intrusion into wakefulness. And so as a patient is maybe waking up, maybe they're paralyzed, and at the same time they're also seeing something spectacular on the wall, like a dream. Okay, so if it happens on falling asleep, we call that a hypnagogic hallucination. If it happens on waking up, it's a hypnopompic hallucination. Now, one thing, and I've learned to mention this because of a lot of emails I get from students, is that many normal individuals experience an episode or two of sleep paralysis or hallucinations on falling asleep or waking up. So if you have that happen once, that doesn't mean you have narcolepsy. It just can happen on occasion. But it is very scary to experience that, waking up, for example, and being paralyzed. Now, just sleep at nighttime is also not normal for patients with narcolepsy. It can sometimes appear like a REM sleep behavior disorder with acting out of dreams, poor quality of sleep, waking up easily at nighttime, right? So their nighttime sleep is not normal. How do you diagnose narcolepsy? Interestingly, you can actually measure the activity of orexin neurons by doing a lumbar puncture. We don't routinely do that. And so diagnosis is made in the sleep lab. And this is done with what's called a multiple sleep latency test. So we'll bring the patient in, get them all hooked up with the EEG and electroocardiogram and all of that. And a patient with narcolepsy, you're going to have them lie in a comfortable chair. They're going to fall asleep consistently within 10 minutes. Now, I would bet, though, a lot of sleep-deprived individuals, you put them in a room in a comfortable chair, a lot of people will fall asleep within 10 minutes. So the difference here is that in narcolepsy, they not only fall asleep easily, but they go into REM sleep. Okay, and again, unlike maybe someone who is sleep-deprived, someone with narcolepsy, you wake them up, and then you do it again, they fall asleep again quite easily. Someone that is just sleep-deprived, once they've fallen asleep for a few minutes, they're not going to again fall asleep quite so easily. Right, so our diagnosis is made, treatment. So to try to maintain wakefulness during the day, amphetamine type medications used to be used, but these we tried to avoid if at all possible. They're addicting, they cause a rise in blood pressure and pulse, and sometimes could even cause some psychotic features. And so modafinil is really quite a helpful medication. So this is not an amphetamine type medication. It increases the release of stimulatory neurotransmitters, especially norepinephrine and dopamine. It also increases histamine levels. So this can be very, very effective, modafinil. For the other manifestations of narcolepsy, like cataplexy, for example, we can use tricyclic antidepressants and SSRIs, if that's a really frequent issue for the patient. All right, now in terms of sleep-disordered breathing, I know you will learn about sleep apnea in other classes, but this is just such a common problem, and I wanted to mention it mainly because of some neurologic symptoms that occur in patients with sleep apnea. So sleep apnea is almost always obstructive sleep apnea, so you can see more common in men. It's associated with obesity, large throats, micrognathia, which is a small chin, along with big tonsils, adenoids, uvula, and just in general posterior pharyngeal tissue. And so I won't ask you about the grading scale here, but we can just notice here from position 1, I can see big tonsils back here, but compared to position 4, where now you can't even see the soft palate. You can only see the hard palate. So just having the patient open their mouth like this can give us some idea of their risk for sleep apnea. And so when you're evaluating someone for sleep apnea, you hope that the spouse is there because you want to hear, does the individual have loud snoring? And frequently the spouse will be aware that they have these episodes at nighttime where they appear to just have apnea periods. Okay, so because of this, and when we do a sleep study, these individuals may have just hundreds and hundreds of episodes throughout the night where they're experiencing apnea. So the quality of sleep is very poor, so they have daytime hypersomnolence. And here is a classic feature of sleep apnea, morning headaches. Okay, so if you're seeing, let's say, an obese man who's having headaches and they're mainly in the morning, really bad when they wake up, that should suggest that the patient has sleep apnea. And so you don't want to just give the patient medications for headaches. You want to make a diagnosis. Do they have sleep apnea? And then treat them for sleep apnea. I won't go into this, but there are lots of medical complications that are very serious in patients that have sleep apnea. So it does need to be addressed and treated. So here is what we would see in a sleep study in someone with sleep apnea. And so here are breaths, okay, but here we have this apnea period. And so as the patient goes longer here without breathing, we can see that there's effort here. We are measuring the activity during this study in the abdomen and the thorax. So we see this increased activity to try to open the throat to breathe again. And then we have another breath, okay, and then again to breathe normally, you've got to get a lot of activity here in the abdomen and thorax to take another breath. Now, we do measure oxygen saturation, and this can seem a bit confusing here because the patient just took a breath and the oxygen saturation continues to decline. And so this is out of sync, and that's just because of the long pulmonary circulation time. All right, so treatment of sleep apnea can be done through continuous positive airway pressure. The patient wears a mask at nighttime. Many individuals find this uncomfortable, and so sometimes compliance isn't very good, weight loss, and sometimes referral to ear, nose, and throat surgery to remove tonsils and things that would be causing obstruction. Central sleep apnea is much less common, but we can have stroke or damage to centers in the brainstem, medulla, upper cervical cord that can impair respiratory centers and cause a sleep apnea. Myotonic dystrophy, I think, is the only neurologic condition that we've mentioned in this course that is associated with a central sleep apnea. And so the major difference here when we do a sleep study is that now it's, there's no central drive when a patient has an apnea period, and so now we don't have that effort in the abdomen and thorax during the spells of apnea. Now, parasomnia is an abnormal behavior that occurs primarily during sleep, and so somnambulism or sleepwalking is very common, about 17% of children. This occurs during the deeper stages of sleep, stage 3, 4. This is hereditary, and people tend to grow out of this as they get older. So this runs in my family. I used to sleepwalk until my teenage years. My sister was a sleepwalker. One of our sons used to sleepwalk. And so individuals tend to wander around the house, usually do fairly non-purposeful things. Our son would come down and try to change the TV channel, opened the refrigerator door and just left it open and just kind of wandered around the house. There have been reports of people cooking during a sleepwalking episode, but they're not normal. They don't do things efficiently. So if you're around someone that sleepwalks, you just try to gently guide them back to bed if at all possible. Now, we've already talked about REM sleep behavior disorder. Remember that this occurs in the synucleinopathies, diffuse Lewy body, Parkinson's disease, and multisystem atrophy. And so this is characterized by loss of muscle paralysis during sleep. So patients act out their dreams, and so it's often dangerous for the spouse because the individual is violent at nighttime. And so treatment, clonazepam, works very well, but melatonin, this is a benzodiazepine that's long-acting, so you're going to give that to an elderly individual and worry that they'll be confused during the day. And so we usually start with melatonin, which is surprisingly helpful for REM sleep behavior disorder. And so here is just a study looking at individuals from the onset of symptoms of REM sleep behavior disorder until they were neurologic disease free. And what we can see is that if we go out to 14 years, 91% of patients had either developed Parkinson's disease, diffuse Lewy body, or multisystem atrophy. And so we don't like to diagnose this in someone because it usually means that they're eventually going to develop one of those three conditions. And safety is a big issue here as well. And there's a lot of nuanced things to say here about trying to protect individuals that have violent movements at nighttime. Night terrors are seen in children, again, during the deeper stages of sleep. And so these kids will wake up usually just screaming, intense autonomic activity. The parents run in, the child is not consolable for a period of time, and then they suddenly just fall asleep. And so this is different than a nightmare. A nightmare is during REM sleep. Okay, and so they're not as intense. You can have a bad dream, it can be terrifying, but it's not the awake, screaming, inconsolable kind of a thing. And because this occurs during REM sleep, and remember REM sleep is a lighter stage of sleep, the child will remember the bad dream and will want to talk about it at the breakfast table in the morning. There's no memory for a night terror. Nocturnal enuresis or bedwetting, again, occurs during the deeper stages of sleep, especially stage 4. And this usually happens due to a maturational lag of the central nervous system. And so with age, that goes away. There are medications that can be helpful for that period of time, or this can be psychological. So the parents are getting a divorce or something like that, and the child may have bedwetting during that period of time. Okay, and finally we'll talk about a little bit about circadian rhythm sleep disorders. So now we have a misalignment between the 24-hour cycle and the external environment. And so this is a spectrum here that kind of, it's hard to say when it goes from normal to abnormal, but I'll start with this one here. Remember teenagers, I said, like to stay up late and sleep in. Well, that can reach such an extreme, and we would call it a delayed sleep phase disorder if it's to the point where they just can't get to class in the morning. It's so extreme. Then we'd call it a delayed sleep phase disorder. And I won't go into the treatment right now. Advanced sleep phase disorder is exactly the opposite and would more likely occur in individuals who are middle-aged or elderly. And now, the bedtime keeps getting earlier and earlier, and they can't stay up past 7 o'clock at nighttime, and then they get up really early in the morning. All right, so these are the two kind of spectrums here. Jet lag disorder is usually when traveling east, and so this is usually occurs individuals that are flying to Europe or something like that, and it tends to be more severe in proportion to the number of time zones that you cross. And basically, the problem here is getting out of your old light-dark cycle and into the new light-dark cycle, trying to reset these circadian rhythms. And so if you've ever flown to, London or something like that, if you have jet lag disorder, you just feel wiped out, lethargic, irritable, sleepy. And so the best thing really in that situation to try to resynchronize, get your circadian rhythms synced up with the new light-dark cycle, is you want to be exposed to light in the new environment for as long as possible. All right, so if you get over there, let's say, at 11 in the morning or something like that, you want to be outside. Don't take a nap. Try to force yourself to be out in the sun for as long as you can, and that will shorten how long it's going to last. Also, you want to time your meals with the new environment where you're in. That will help to entrain the circadian rhythm. It can be helpful to take melatonin for a few nights before you leave on the trip. And caffeine can actually be quite helpful. Again, you're trying to be out in the light, and so, have a cup of coffee or something like that to promote wakefulness. Stay awake during the afternoon, and then try to go to bed as close as you can to the desired time to go to bed in the new environment. All of that can be helpful.